Hello and welcome everybody. I'm Anthony Gonzalez and I'm the Senior Program Coordinator with the Higher Education Center for Alcohol and Drug Misuse Prevention and Recovery. And I want to welcome you all today to our webinar titled Preventing Opioid Overdose in Higher Education Setting, featuring our presenter today, Dr. Christina Freibott. Before we get started with today's content, I do just have a couple of housekeeping slides I'd like to share with everyone. Here on the screen should look somewhat familiar as we are in the Zoom webinar format. We do welcome your questions throughout today's live session, but we do kindly ask that you utilize the Q&A feature. We do have the chat enabled, so please feel free to introduce yourselves and share reflections and resources as it relates to today's content. But again, we do kindly ask if you have specific questions for our presenter that you utilize the Q&A feature. We also have live captioning enabled for today's session. You can turn that on through your bottom dashboard. If you have any issues getting that set up, please send me a message and I will try my best to walk you through that process. We also encourage everybody to learn more about becoming a member of the Higher Education Center. You can learn more about the different membership tiers and the benefits that go along with them by visiting our website at hecaod.osu.edu. We also have a few upcoming events I'd like to share with everybody. Our next webinar will be taking place December 3rd and is focusing on Communication Toolbox, Building Effective Strategies for Alcohol and Drug Prevention Communication. We also have our 2025 Cannabis Symposium taking place the next day on December 4th and is in a full day symposium format. And registration is now open for that. You can view the full agenda by visiting our website. And then our next water cooler chat will be building on those conversations, and we'll be focusing on cannabis on campus, continuing the conversations. And that water cooler chat will be taking place on December 9th. And with that, it is my great pleasure to turn it over to our presenter today. Joining us today is Dr. Christina Freibott, postdoctorate associate with Boston University. Thank you so much for joining us today, and it's my pleasure turning it over to you at this.
All right, thank you so much. Let's just get these slides going. All right, well, thank you all so much. I'm so excited to be here today talking about some of my research around preventing opioid overdose in higher education settings. And just a quick overview of what we're going to talk about today. I'm going to walk through sort of an introduction to the topic, go through the learning objectives for this webinar, some background, as well as the specific research studies that we'll be talking about, including a scoping review, a policy tracking database, a latent profile analysis, and some interviews with higher education leaders. We'll go through some conclusions from those research studies and some next steps as well. Just a quick funding disclosure. All right, so the learning objectives for today. Our goal is at the end of this to be able to describe the prevalence and risk factors of opioid overdose among college students, to evaluate effective campus-based strategies for overdose prevention, understand the current federal, state, and institutional policies influencing prevention efforts, and to examine the connections between opioid misuse and mental health. Okay, so just going to dive into some high-level background before getting into the more specific research findings here. More than 1 million people have died since 1999 from a drug overdose, the main driver of which are opioids. Now, the opioid crisis is typically described as evolving in 3 overlapping waves, and we may now be experiencing an emerging 4th wave, which is indicative of a broader shift in the crisis to opioids being used in conjunction with other substances, such as cocaine and psychostimulants with abuse potential. One demographic of particular concern in the opioid crisis are adolescents and young adults. Due to the potentially compounding effects of opioid misuse early in the lifespan, adolescents and young adults are deemed a priority population. The rate of unintentional drug overdose deaths increased 147% between 2015 and 2022, despite otherwise stable rates of substance use in this age group. And this is primarily due to the increasing presence of fentanyl in the illicit drug supply, as overdoses involving fentanyl tripled among adolescents and young adults between 2019 and 2021. Even more concerning is that fentanyl is being added to non-opioid drugs, which implicates a much broader range of adolescents and young adults beyond those who knowingly use opioids. So despite the increases in overdose fatalities among adolescents and young adults, there's limited public health research on a national level to inform education and prevention efforts. So a significant portion of the public health response centers around preventing opioid overdose fatalities, reducing harms associated with opioid misuse, and treating those with opioid use disorder. Experts and advocates in the field point to the comparative lack of research on prevention strategies to be a significant weakness in the public health response. Much of the current approach to the opioid crisis relies on the healthcare system to screen for, identify, and treat opioid misuse, but this often occurs at a juncture when opioid misuse has become severe enough to warrant an emergency department visit or long-term treatment. Policies and best practices are not designed for adolescents and young adults outright, but are instead adapted from their adult context. So when discussing adolescents and young adults, an important setting to consider is higher education. As more than 20 million are enrolled in US colleges and universities, this makes it an ideal setting to employ upstream prevention strategies for opioid misuse. Many schools have existing public health focused programs, such as bystander sexual assault training, suicide prevention, and substance use education programs. And while these programs vary in content and methods, they share a common goal of preventing a multitude of short and long-term negative outcomes and improving the well-being of adolescents and young adults in the college setting. So some relevant higher education dynamics to consider are both substance use and mental health. The college years typically coincide with the initiation and intensification of substance use, which can affect cognitive development, academic success, and employment opportunities. Further, the 18 to 24 age range, which encapsulates the majority of college students, coincides with the age of onset, or the time when symptoms of common mental health problems first emerge. More than a third of college students have moderate to severe depression or anxiety symptoms, which is concerning as mental health in college is a strong predictor of academic performance and student retention. And importantly, up to 45% of adolescents and young adults with mental health disorders have a co-occurring substance use disorder, and more than 65% with a substance use disorder also have a mental health disorder, making programs that address both components of the utmost importance, particularly in the higher education context. So in terms of policy responses, as of 2024, at least 7 states have passed laws relating to opioid overdose education or access to opioid antagonists such as Narcan, which is an FDA-approved over-the-counter nasal spray that can reverse an opioid overdose. These laws vary in scope and content, with some only requiring access to opioid antagonists, while others mandate education and training for students, faculty, and staff. So here's an example of one of these laws from Washington State, where you can see its focus on institutions of higher education, including both public and private institutions, to provide opioid and fentanyl prevention education, which includes naloxone and fentanyl test strips, as well as training staff that work in residence halls to be able to administer naloxone. So these are the overarching questions guiding my research thus far in this area. The first question is, what is already known about how colleges and universities approach opioid misuse and overdose prevention for their students? And to do this, we'll be talking about a scoping review and policy tracking database. The second was, what do students know about opioid overdose signs and symptoms, and how comfortable are they in intervening during an overdose event? And for this, we did a national survey of college students. And lastly, how are higher education leaders approaching overdose prevention and naloxone training on their respective campuses? To which we did interviews with higher education leaders. And I'm going to touch on some high-level results from the first 2 studies, but I'm going to focus mostly on this third question surrounding higher education leader perspectives. So again, to answer that first question, we conducted a scoping review in conjunction with a policy tracking database. So colleges have a number of substance use focused programs to promote health and well-being of their campus community. And these programs vary by school in both content and methodology, but they typically focus on alcohol, tobacco, and cannabis, as they're the most commonly used substances in this age group. However, due to increases in opioid overdose fatalities among adolescents and young adults, many schools are revisiting their programs to include opioid overdose prevention and naloxone training. And while there are many studies on approaches to alcohol, tobacco, and cannabis programs and policies for college students, there is no existing review summarizing the institutional approaches to opioid misuse and overdose. So the objective of this scoping review was to identify studies that report efforts to prevent opioid-related harms for students in U.S. higher education using the opioid use disorder cascade of care framework, which we'll talk about right now. So while a systematic review summarizes the best research on a specific question, the primary purpose of a scoping review is to provide an overview of the available research on a topic. So we use this opioid use disorder cascade of care as a way to organize the results of our scoping review, which describes the continuum of approaches to opioid use disorder through 4 interrelated domains, which are primary prevention, secondary prevention, treatment, and recovery. And of note, this is not a linear progression, as individuals can move forwards or backwards or skip steps depending on their individual circumstances. So again, I'm just presenting some high-level results. So I'm jumping right to the results. I'm happy to talk about the methodology here a little bit later. But this is a breakdown of the studies that we found within each opioid use disorder cascade of care domain in terms of the number of articles. Subcategories were included to further organize the reporting of results within each domain. And a number of included studies discussed programs that have multiple components relating to more than one of these domains. So studies were categorized based on their primary focus. So first we had primary prevention, which had 28 articles, which focused on prevalence and correlates of opioid misuse, student knowledge, attitudes, and beliefs, risk perceptions, and comprehensive approaches. Within secondary prevention, there were 10 articles that focused on programs or policies relating to harm reduction and screening for opioid misuse. The treatment category had 6 articles, which focused on treatment services for college students, as well as student perceptions of treatments. And lastly, the recovery category focused on supporting recovery process or components of a recovery program. So in summary, what we found with the scoping review, which is currently under review, is that this was the first to summarize current efforts to prevent opioid-related harms in higher education settings. The main findings include the need to develop campaigns that emphasize single-use risk and address misperceptions of peer use, as college students may be more likely to engage in prescription drug misuse if they perceive it as normalized within their peer group. An increasingly common approach to overdose prevention on college campuses is to store naloxone with or next to automated external defibrillators, or AEDs, with creating this emergency response area, specifically in dorms or on-campus housing or easily accessible buildings like libraries. From the treatment perspective, buprenorphine can be safely and effectively prescribed for students, but it's typically beyond the scope of most college health practices. And lastly, student health services providing opioid use disorder treatment should offer both medications for opioid use disorder and 12-step recovery program to appeal to a wide range of students. Okay, so in terms of the policy tracking database, each college and university has their own set of institutional policies, which often include Good Samaritan or medical amnesty policies. And these policies protect students who seek help during substance use related emergencies and have been reported to increase help seeking for alcohol related emergencies, but are poorly understood in the context of help seeking for opioid overdose events. But despite increasing rates of opioid overdose among this population, little is known about the landscape of opioid overdose prevention policies at colleges and universities in the US. So the objective of this policy tracking database was to capture the presence or absence of opioid-related policies at colleges and universities across the US. So sort of moving beyond what's been published for the scoping review and also capturing things at the policy level. So here's an example of BU or Boston University's Good Samaritan policy and overdose prevention program, both of which are found on the Student Health Services website. The Good Samaritan policy protects students who seek help during a drug or alcohol-related emergency. And the overdose prevention program trains students, faculty, and staff on identifying overdose signs and symptoms, administering naloxone, and performing rescue breathing. So what we found, we looked at 152 schools that were included based on their participation in the Healthy Mind Study, which we'll talk about in just a little bit, but it's a national survey of college students. A systematic search of each institution's website was conducted to identify their alcohol and drug policy and any related opioid programs or policies. Policies were coded as present or absent, and the full text of each policy was cataloged. And here is a map of all the included institutions, as well as some descriptive characteristics of those that were included. So on the right here is a snapshot of our findings, with 0 indicating no policy and 1 indicating presence of a policy. And we found that of these schools, just over half had Good Samaritan or medical amnesty policies. 27% described options for substance use treatment. 22% had naloxone available on campus, with 18% offering training to students on how to use naloxone. And 16% had dedicated opiate overdose prevention programs. However, less than 7%, or just 10 of these schools, had policies or programs in all 5 categories. So in summary, this database systematically catalogs the presence or absence of opioid-related policies across a diverse array of colleges and universities in the US. We found considerable variation in the description of these policies, as well as the protections that they afford, and that implementation varies significantly across institutional contexts, which is influenced by state policies, community partnerships, and internal resources. So some next steps we have planned here is to include a more comprehensive analysis of the content and scope of these policies beyond just presence or absence on a given college campus. All right. Now moving into the second question, which we answered with a national survey of college students. So like I said earlier, I'm going to talk a little bit more about the Healthy Mind Study, which is a national survey of college students that examines mental health, service utilization, and related issues among undergraduate and graduate students. And beginning in winter 2021, the Healthy Minds Network launched a faculty and staff survey in addition to their student-focused survey to help institutions understand their faculty and staff's mental health and perceived ability to help students with mental health concerns. So this is a really great data resource that's publicly available, and it's the focus of what we used for this study. So more specifically, we added 4 new questions to the substance use module of the 2021 to 2022 Healthy Minds Study. And these are listed in Table 1, and the questions focused on naloxone knowledge, overdose recognition, naloxone use, and willingness to intervene. So over on this table, you can see the question, the response options, and how it was coded as correct or incorrect or agree, disagree. So we found that just over 30% of students could correctly identify what naloxone is used for. Over 60% could correctly identify at least one sign of an opioid overdose. Less than 15% knew how to administer naloxone, while more than 2/3 felt comfortable calling emergency services during an overdose event. We did also find significant differences by age, race and ethnicity, gender, and sexual orientation in the responses to these questions. So while this study was an important first step in understanding the baseline levels of knowledge, opioid-related knowledge, it's hard to inform policy and practice with such high-level descriptive data. So we sought to take this one step further to be able to identify patterns of opioid-related knowledge and understand who may intervene during an overdose event within this student sample. Existing research shows that more than 2/3 of opioid overdose fatalities between 2019 and 2021 among adolescents had one or more bystanders present, but no bystander response in 70% of those overdose deaths. College settings are unique as students live, work, and socialize together and have influence over each other's perceptions and actions. And prior research has also shown that while the majority of college students are willing to call for help during an overdose, there are relatively low levels of opioid-related knowledge within this population. However, those that received naloxone training had greater knowledge of overdose risk, signs, and bystander actions than those without training. And prior studies typically focus on associations with a single outcome, but they don't consider the social and community factors, which are crucial to include for the college setting. So the objective of this study was to look at distinct patterns of opioid-related knowledge, social relationships, and campus connectedness to better understand who may intervene during an overdose and why. So to do this and to take this one step further, and incorporate these social and community factors, we employed a latent variable modeling approach. So this is a person-centered approach that groups people together based on how they respond to indicator variables or specific questions that are deemed indicator variables, rather than comparing individual variables to each other. And we specifically conducted a latent profile analysis, which uses continuous variables to identify groups of individuals with similar patterns of responses. So another way to sort of look at this, to further illustrate this approach, imagine this is the number of drinks per day in a survey administered at 3 different time points to college students. We may find that the sample mean is 5 drinks per day across 3 time points. However, what may be happening behind the scenes is that 50% of the sample could be increasing their alcohol consumption, and 50% could be decreasing their alcohol consumption. So it would be important to understand who comprises each of these groups when designing a public health intervention related to alcohol consumption. So when using this latent profile analysis approach, we used the same data source as that preliminary analysis, but simply included more questions that could be used as indicator variables. For our study, we included 8 indicator variables that address these opioid-related knowledge, social relationships, and campus connectedness of college students to understand how those factors combined contribute to action during an overdose scenario. And this is how we thought through which variables to include as indicators, specifically using self-categorization theory, which posits that individuals derive a social identity from groups with which they feel connected, adopting group goals and motives as their own and acting on behalf of the group when that identity is prioritized. Campus connectedness has been defined as a student's sense of belonging and fitting in with their college community. So applied to this study, we said students who feel a strong sense of connection to their school may be more motivated to protect fellow students and promote campus safety, increasing their likelihood to intervene during critical situations. So this is why we included the social and campus connectedness variables in addition to the opioid-related knowledge variables. So within this sample, of the just over 7,000 student respondents, 67% identified as heterosexual, 66% as female, 65% identified as white, and 32% were first-year students. And the average age was 20.6. This is a map here of the schools that were included across 17 colleges and universities, with the green markers indicating schools that had opioid-related policies, and the red were schools without opioid-related policies. So when conducting the latent profile analysis, you identify the optimal number of latent profiles, and that's determined using model fit indices such as the AIC, the BIC, the LRT, entropy, and profile size. So I'm skimming over this process a little bit, but again, happy to delve more deeply into it later. But for now, based off of the model fit indices, the 4-profile solution was deemed the best fit to our data. So how we actually use those model fit indices to describe each of the 4 latent profiles is as follows. We found of the 4 latent profiles, these are how students responded to the questions. There was a 14% of the sample were in this high knowledge and willing to intervene group. So these were students that knew how to use naloxone, could identify more than 3 signs of an opioid overdose, and were not concerned about calling emergency services. There was a 12% group that was disconnected from campus and resources. So they were students who did not feel part of the campus community, did not know where to seek help for mental or emotional health, and did not know how to use naloxone. 14% were in this neutral or hesitant group. So they were students who were the most concerned about calling emergency services during an overdose event, but they did feel connected to their campus and peers. And lastly, the largest group, 60% of students were in this low knowledge but willing to intervene group. So students that had the lowest levels of opioid knowledge, but were the most willing to call for emergency services and feel connected to their peers and campus community. So this would be like your average college student based off of this analysis. So here we're breaking down the profiles by indicator variables using z-scores, which standardizes the score's value to the mean to easily compare across the indicator variables, which had different response options. So you can see how the responses to each question varies by profile. Specifically for the naloxone use question, knowing how to use naloxone, the high knowledge and willing to intervene group had way higher levels compared to the other three profiles. So when looking at the social and campus connectedness questions, the starkest difference here is for the disconnected from campus and community resources group, which have much lower values for all four indicators as compared to the other profiles. So much lower values for campus belonging, rewarding relationships, positive relationships, and campus resources. So this is the first study to use a person-centered approach to identify profiles of college students and their willingness to intervene during an overdose scenario. And we found that the majority of students are willing to intervene despite low levels of opioid-related knowledge. Our results can guide intervention planning for colleges that want to implement or augment existing programs tailored to their student community. And the disconnected group is one that's typically missed by traditional interventions, but are potentially the most susceptible to an overdose. Future research should explore if or how school level policies affect student bystander behavior. So school level policies like the Good Samaritan or medical amnesty policies, as fear of disciplinary consequences may inhibit action, regardless of the resources available. Okay. So moving into this third question, where we talk to higher education leaders, specifically titled Higher Education Leaders' Perspectives of Student Opioid Misuse and Opioid Overdose Prevention Programs at U.S. Colleges and Universities, an exploration of implementation facilitators and barriers. It's a mouthful. So college and university campuses are a unique setting for the implementation of public health interventions, offering the potential to target a wide array of health challenges, and particularly as a platform for addressing the opioid crisis. A recent study examined facilitators and barriers to an overdose prevention program on a single campus, but did not explore higher education leaders' perspectives, which are a crucial determinant for program implementation. And understanding the decision-making process of institutional leaders when advocating for these programs is critical in guiding future interventions. So the objective of this study was to explore institutional leaders' perspectives of student opioid misuse and overdose prevention programming in the college setting using an implementation science framework. So we recruited higher education leaders via email from schools that participated in the Healthy Mind study, and they were invited to take part in a 30-minute interview. We used maximum variation sampling and invited leaders from schools of differing size, geographic location, academic rank, and opioid-related policies. And of note here, higher education leaders are defined as directors of student health services, directors of student wellness and health promotion, alcohol and other drug services, counseling centers, or equivalent roles. A semi-structured interview guide was developed and informed by CFIR implementation outcomes, which include innovation, outer setting, inner setting, individuals, and implementation process. And the questions in our interview guide were adapted based on presence or absence of opioid-related policies on their respective campus. And just a note on CFIR, which is the Consolidated Framework for Implementation Research. It's a comprehensive framework that consolidates concepts from a wide array of implementation theories to understand what program works best in which setting and why. So the original CFIR model was established in 2009, and was updated in 2022 to CFR 2.0, which is what we used in this study. And this model or diagram demonstrates how the 5 domains intersect in order to better understand the variety of factors that can affect implementation process. And importantly, CFR has been previously adapted to the college setting to examine the implementation of an opioid overdose and naloxone training program at a single institution through focus groups. So this study sort of expands on that initial adaptation. So interview transcripts were coded in vivo using deductive codes of CFR domains and constructs. Each question on our interview guide maps to a specific CFR domain or construct. As you can see in this figure below, you can see each individual question and probe and the related domain construct or subconstruct. So that guided how we coded this qualitative data. A thematic data analysis was performed, again, guided by the CFR model, where deductive codes were iteratively compared to identify patterns across the data from which we derived themes. And two researchers double-coded the first 3 interviews, discussed inconsistencies, and iteratively reanalyzed until reaching consensus. So on the right here is a map depicting all of the schools included in the sample we recruited from, and then stratified by opioid policy status. So again, green meaning has an opioid-related policy or program, and red meaning they do not. And lastly, this was our final sample of 25 schools that were included for these qualitative interviews. And of the 25 interviews conducted, 14 were at schools with opioid policies and 11 without. Geographically, 12 institutions were in the South, 5 in the Northeast, and 4 in the Midwest, and 4 in the West. The average undergraduate enrollment of those schools was 12,000. 12 of the interviewees were directors of their department, and 8 of them worked in wellness departments. So from our coding and thematic analysis, 4 main themes emerged. Theme 1 was shifting the narrative of opioid misuse and overdose to broaden the support for resources. So within this theme, participants described the notion that opioid misuse and overdose was not perceived as a problem at their institution, particularly by administrators. They also felt that a lack of student-level data suggesting a meaningful percentage of students misuse opioids often raised questions of resource allocation and the necessity of investing in prevention or naloxone training. However, they found that reframing the traditional conception of opioid misuse to poisonings or one-time or infrequent usage of a non-opioid substance, which has been laced with fentanyl, increased administrative buy-in, often around sort of broadening the population of interest and sort of pointing to how this could affect students beyond those that are knowingly using opioids. So here's a quote where one participant says, "I've been doing alcohol and drug education work for 30 years. And to me, this is probably one of the most trying issues we're seeing because there's no margin for error. One pill can literally kill. It's basically poisonings or what's happening with fentanyl. Students are taking a pill thinking it's Adderall or Xanax and figuring out it's laced with fentanyl, which leads to tragic results." So theme 2 described internal and external advocates for implementation. So within this theme, participants described partnering with many different campus groups, including student organizations that were health-related or Greek life, also partnering with faculty or athletics departments. They described some policies that required school-level action or made implementation easier, such as state policies that mandated access to opioid antagonists like naloxone, while other policies restricted implementation, such as states where fentanyl test strips are considered drug paraphernalia, or those restricting education on subjects that are considered divisive concepts. And lastly, participants described being part of the community at large as a driver for implementation, that college campuses don't exist in a vacuum, but instead are part of a broader community for which these resources are beneficial. So again, a quote from one of the participants, "You live in a community I told the administration we need Narcan all over our campus because it isn't just the students that come into the health clinic or see the police. Drug use is much bigger than just our students. A student's family can be defined as their roommate or their friend that goes to another college or the guy they go drinking with that owns the bar. And we have to remind ourselves that at this school is in a county with the highest drug trafficking in the state. So to me, it's wider than the college students. Theme 3 was collaboration is key. So participants described several within campus partnerships that helped spread awareness of existing resources or alleviated the burden of delivering programming themselves. For schools without the internal resources to conduct their own overdose education, partnering with community organizations enabled them to give students access to this information. And additionally, many participants described learning about other schools' approaches through professional networks such as conferences, speaking with colleagues at nearby universities, or researching programs on college websites. So here's this quote from a participant saying, at another school has a really good program with One Box, where I actually spoke with the director of that program there about how they were able to get going. But that's something we hope to mimic because I think that it's very helpful, especially with the videos of how to use it, being able to eliminate some barriers with language and also having it in different languages. So our last theme, theme 4, encapsulated the common pathway to acquire, establish, and sustain resources. So this theme further detailed the pathway through which schools often implemented opioid overdose education and naloxone training programs. So first, schools without internal funding or support to establish would partner with outside organizations that could deliver programming to their students or on their campus. Then this would sort of garner internal buy-in, and they would expand their own capacity to distribute naloxone. And lastly, they would establish an in-house opioid overdose education and naloxone training program for the campus community. So no longer relying on outsourced resources, but having their own internal program with which to deliver this education and programming to students. So here's a quote from a participant saying, we've partnered with a local organization who has a lot of really great grant funding, especially pertaining to opioid use. They've done a whole bunch of Narcan trainings this year for us, and we had 3 different ones for students, faculty, and staff. They've also provided Narcan, which is now in all of our first aid kits all over campus and with RAs, resident advisors. And because we're such a small school, we really need this community partner group to come in and be the experts and to do this work. So in summary, this is the first multi-campus study to explore higher education leaders' perspectives of student opioid misuse and overdose prevention programming in the college setting. We found that leaders often reframed the traditional concept of opioid misuse and overdose as poisoning to increase the acceptability by broadening the scope of potential students affected. Internal and external advocates increase institutional buy-in, facilitate program implementation, and foster sustainability of existing programs. The use of CFER highlighted a pathway by which colleges and universities implemented programs, garnering external support, expanding internal capacity, and then establishing an in-house program. However, challenges such as financial constraints, institutional resistance, and legal hurdles point to the need for continuous adaptation and flexibility in program design. Okay. So some conclusions, key takeaways, remaining questions, and next steps. So key takeaways from these studies sort of in aggregate. The majority of existing studies focus on prevention, often using cross-sectional surveys at a single institution. So that stems sort of from our scoping review. Nearly 2/3, more than 60% of college students are willing to intervene despite low opioid-related knowledge. And lastly, phased implementation and ongoing adaptation of opioid overdose prevention programs is key in overcoming barriers. Okay, so some remaining questions that I have after doing these 4 research studies include quantifying overdose prevalence among college students. So though We have mortality data, publicly available mortality data on opioid overdoses for the broader young adult population, specifically ages 18 to 24. There's no national data source that currently reports overdose deaths specifically among post-secondary students or college students, which is a critical gap that limits our understanding of the scope and urgency for targeted policy interventions in the higher education setting. So like a lot of these state level policies, the advocacy for it would be perhaps stronger if there was actual data that could be referenced on a national level around overdose deaths among college students. So a study that's currently under review, sort of a work in progress, we used CDC and NCES, or National Center on Education Statistics data, to estimate the number of overdose deaths among college students between 2018 and 2023. And we found that approximately 13,000 post-secondary students aged 18 to 24 died from a drug-related overdose within that time frame. So this is an estimation, and it sort of provides a framework in combining two publicly available national data sources, but it's helpful in understanding the magnitude of the problem and underscores the importance of state policies requiring naloxone access and training in higher education settings. So some future directions for this work will include exploring student awareness of opioid-related programs or policies at their school, including Good Samaritan or medical amnesty policies, overdose prevention programs, naloxone training programs, or having naloxone accessible on campus, as well as collegiate recovery programs. And this is sort of getting at how successful can these programs be if students aren't aware of them? Will students intervene to help if they are or are not aware of the policy that exists at a school level that's protecting them from disciplinary consequences? We're also including questions. We also included questions assessing students' likelihood of seeking help for substance use using school resources. So the addition of these questions to the most recent 2024 to 2025 Healthy Mind study stems directly from the research that we just covered today, and is going to sort of help in better understanding student knowledge of campus policies and resources that can identify gaps in the current approaches to overdose prevention. And one additional area that we'll be focusing on are collegiate recovery programs. So these are system level interventions which offer a range of evidence-based services to the more than 400,000 college students that identify as in recovery from drugs or alcohol. CRPs are often key providers of substance use education to the entire student body, regardless of recovery status. So more than 176 colleges have a formally recognized collegiate recovery program, but less than 30% of students know if their school has a collegiate recovery program. So again, sort of pointing at the importance of awareness and how plugged in are students to the resources that their school is offering them that could help them in this realm. 1 in 5 students in recovery report substance use in the past 30 days, which is similar to the rates of students who are not in recovery. I have an asterisk here because that's preliminary data analysis that has not been published, but it is comparable to existing research that shows similar rates of substance use among students in recovery and students who are not in recovery. This is more of an evolving, more definition-based finding where young adults in college are self-identifying as being in recovery from a specific substance, but still actively using another substance. So in recovery from alcohol, but still actively using cannabis. So it's just sort of a different way of approaching as compared to the more abstinence-based concept of recovery. And lastly, 1 in 3 CRPs provide overdose education and naloxone training to their campus and community. So again, this intersection of collegiate recovery programs being a hub of substance use education for the entire campus community, not just students that may be in recovery from alcohol or drugs, and being the provider of these types of prevention-based resources or harm reduction-based resources like overdose education and naloxone training. So the intersection of all of these things is something that we'll be looking at moving forward. And that is everything that I had today. So I welcome any questions that may have popped up in the chat or Q&A, and I will stop sharing for now.
Well, thank you so much, Dr. Freibott, we did have some questions come in, and of course, we welcome any questions that our audience has. Please utilize the Q&A feature for those specific questions that you have for our presenter today. One of the questions that came on kind of earlier on in the session, someone was interested if you had any recommendations on how best to find out which states have passed laws around opioid antagonists.
It's a great question. It's one that I wish I had a better answer for besides myself going and looking at individual states' legislation. There are a number of states that have these policies under review. For example, Massachusetts has one that in the state legislature, in the Committee for Higher Education, that would require public institutions to have naloxone available and overdose education and training to their campus community, students, faculty, and staff. There are um, opioid specific or drug specific policy tracking websites. I have not seen this specific type of policy on those websites yet, but if I find that information, I would be happy to share with Anthony, who can disseminate. But that is also an area that would be helpful to be able to catalog exactly which states are doing it and how they're doing it.
Awesome. Thanks, Dr. Freibott. Second question that came in, it's was about is about health centers and treatment. Is that are you aware of how many health centers currently offer treatment for OUD? And what types of campuses are they? Are they mostly 4-year? What other kind of parameters do they have? And because this person comments treatment would seem kind of beyond most institutions, or what does the relationship look like from campus to like treatment facilities?
Yeah, that's a great question. It's the kind of thing that the policy tracking database was just starting to get at just by looking at sort of presence or absence of having treatment options available. I would say because it's beyond the scope of a number of student health services to provide that type of treatment, what schools often do is have dedicated referral pathways to either local resources or have information on their website as to where students can go to access that information. I do not know beyond what was in the policy tracking database how many schools in the US offer this type of treatment, but I do know it exists a lot of times with larger 4-year institutions that have large student body and have affiliated like schools of medicine and schools of pharmacy and may have like a more robust campus community from which they can provide these resources. But yeah, that's a great question.
Thank you so much. We had another question come in and it says research has suggested significant difference between community college students versus those at 4-year college and universities in substance use pattern. Is data on overdoses also analyzed similarly?
Um, this is a good question. If I'm understanding it correctly, in terms of what I was just presenting at the end, in terms of overdose deaths within post-secondary students, that was looking at full-time enrolled post-secondary students. So at 4-year institutions. So we picked like the smallest, most specific sample, so it's not to overrepresent the number of overdose deaths that may be experienced within college students. With regard to the variation in campus structures in 2 and 4-year and community colleges, there are differences in how these overdose prevention programs are implemented. I did talk to a number of different types of schools. And for example, like commuter schools were not often very interested in having sort of in-house dedicated programs, but were more interested in having like an online version or having information on their website that their students could access just because there's less of a presence of on-campus living, obviously, with commuter campuses. So it was just a different approach to being able to provide those resources. So I'd imagine the same thing, very common, similar way to approach that with community colleges as well.
Thank you, Dr. Freibott. A bit of a technical is not the right word, but I think just information from the research. I believe this came in when you were going through the first study.
Okay.
Do the publications of your studies, do they identify which schools were studied or just give like information about the schools?
Sometimes they identify the school by name. oftentimes they'll identify like type of institution, so public or private or student body size or region. It also sort of sometimes depends on like the journal requirements. That a lot of times journals don't want it to be identified in that way, but there is always some sort of qualifying characteristic in terms of what type of school. It may not be the actual like name of the school, but there is some description of what type of school and how large and where it's located.
Awesome. Quick follow-up. Can you just remind us the name of that study, or at least the first? I think I found it, and I was going to post it in the chat if that's the correct study.
Of the scoping review?
Yeah. Was it
It is,
interventions to increase naloxone access
oh,
for undergraduate students?
that is a different. So I also did a systematic review
Okay.
looking at specifically at interventions that increased, like you just said, access to naloxone. So that was like a more
Yeah.
specific and focused topic on what has been published specifically for programs that increase that are naloxone focused, not just general overdose education or opioid
Okay.
misuse. And there were 7 studies in that article, so it sort of points to there are many, many more schools than those 7 that are offering these types of programs. So that was sort of the nature of the scoping review, just sort of cast a wider net and understand more about what's going on that may not have been published in that specific way.
Okay. Awesome. Thank you.
Yeah. Yeah.
So we had a person say that they really appreciate your work and that they are beginning a research project around recovery services on their campus, and they are disheartened but not surprised to see the lack of info and articles on recovery on campuses. They also highly agree that campus resources should be community facing. Do you have any examples of strong partnership between campus and community?
Yes, and also I will say with regard to the recovery findings in the scoping review, we had a narrow focus in that we wanted recovery focused articles that specifically mentioned opioid misuse or overdose. So that were focused on students that were in recovery from opioid use disorder or somewhere along that opioid specific spectrum. So there is a broader literature on collegiate recovery programs and recovery among college students. So don't be too disheartened. There are many, many articles available that just weren't specific to this scoping review topic. With regards to campus-based partnerships, there's a couple of different ways that the higher ed leaders described to me having those like integrations. So one was a leader that was in a state that did not allow with federal a school with federal funding that was not allowed to have this type of training on their campus. So they partnered with the local Department of Health that offered naloxone training to come in, because as long as it wasn't a school representative that was offering it on their campus, it was allowed. Another was that in a given county, this higher ed leader, who is the director of a student health service center, was plugged into the local DEA statistics in the area, so within the Department of Public Health and the DEA statistics of the county. So they were aware of the levels of fentanyl in the local drug supply. And when they found that there were very high rates of illicit fentanyl in the local community drug supplies, when they were more driven to sort of bring this overdose education and naloxone training to their students, because they were worried about sort of the spillover effect between the two, since campuses and communities integrate very seamlessly.
Last question we have for you, Dr. Freibott, is just a statistic clarification. Towards the end, you provided the number of college-age students that have died from an opioid overdose. Can you just reiterate that statistic for us?
Yes. So again, this is a work in progress, and we combined publicly available CDC data on drug overdose deaths in the 18 to 24 age group with education enrollment statistics from NCES. So these were full-time enrolled post-secondary students that are aged 18 to 24. So, and the finding was that there were just under 13,000 drug overdose fatalities within this population between 2018 and 2023. The main driver of which, 75% of which were illicit synthetic opioids. So fentanyl. But yes, hopefully that finding becomes more widely acknowledged at some point, pending publication.
Thank you so much, Dr. Freibott. We did have just one other question before we close today.
Sure.
Which department in university campus do you recommend coordinating AED, and naloxone to grant permission for them to be placed together? They really think this is a great idea and would just love some feedback or
Mm.
guidance.
That's a great question. I would imagine that will differ based on your individual college circumstances. I know a lot of times, so like resident advisors were, or the group associated with in on-campus living had to obviously have buy-in. And most of the overdose prevention resources, when I spoke to the higher ed leaders, were advocated for by students. So it was student driven. So if there's a desire among the student body to have these resources available, that's a main driving force behind the onset of these resources on campus. But I know a lot of schools went through legal conversations and administrative conversations around being sure that they have everyone appropriately trained and having the financial resources to buy the do the co-boxing with AEDs. But yeah, I think it would depend a little bit more on your individual context.
Well, thank you again so much, Dr. Freibott, for sharing of yourself and of your research. Of course, take a look in the chat as people are very grateful for your content today. I do just have a couple of housekeeping slides I'd like to share with folks before we close. Again, we just have a few upcoming events taking place. We have an upcoming webinar taking place on December 3rd, and that one will be focused on communication toolbox, building effective strategies for alcohol and drug prevention communication. We also have registration open for our 2025 Cannabis Symposium. You can view the full agenda by visiting our website, and then we'll be continuing that conversation from the Cannabis Symposium in our next water cooler chat around cannabis on campus, continuing the conversation, and that one will be taking place on December 9th. And with that, just a friendly reminder that today's session has been recorded and you can expect to see it uploaded to our website within 3 to 5 business days from the live session. Additionally, there is an evaluation that will open up in your browser as you leave today and will also be found in the follow-up email that you receive tomorrow. So please provide us feedback from your experience and share topics that you're interested in hearing from as future topics for webinars. Again, thank you to our presenter and thank you to all who joined us. I hope you have a great week and we hope to see you soon. Take care, all.